Hello, everyone, and welcome back. My name is John, and I'm one of the final year critical care fellows at Dalhousie University. Thank you so much for tuning in today for part 6 of my 7-part learning module on oxygen delivery and oxygen consumption for the evaluation of oxygen balance and hypoxemic respiratory failure requiring VV-ECMO. Last time we discussed the role of hemoglobin in oxygen transport and the technology behind and shortcomings of pulse oximetry. Today we'll be discussing oxygen content, oxygen delivery, and oxygen consumption. And the overall objectives of this portion of the lecture series is to discuss the concept of oxygen content, discuss the concept of oxygen delivery and the factors that impact it, discuss how to assess and calculate cardiac output, and discuss the concept of oxygen consumption and the factors that impact it. As we begin to understand the shortcomings of pulse oximetry and fully assessing patient oxygen balance, we can begin to appreciate the need for a more useful measure for assessing overall oxygenation for our patients. And with this revelation, we have arrived at one of the main purposes of this presentation, which is to introduce, discuss, and learn about the concepts of oxygen delivery and oxygen consumption. To begin, we'll start with the introduction of the concept of oxygen content. We can all likely remember an ABG analysis that looks something like the ABG below, where a patient has a PaO2 that is technically low and in fact in the range that meets the definition of hypoxemia as defined by PaO2 of less than 80. But interestingly, with a normal SO2 or SaO2 or SpO2 by pulse oximetry, as well as a normal concentration of hemoglobin. Often, despite the aforementioned abnormalities, there are no changes required to the amount of supplemental oxygen being delivered to the patient or changes to the FiO2 on the mechanical ventilator if once in use. To understand how this or any level of hypoxemia can be safe for a patient, we can look at the ABG analysis provided to calculate the overall oxygen content of the blood sample. And in doing so, we can learn about the factors that impact oxygen content. To start, the term oxygen content, which is a value calculated from a sample of blood, reflects the total amount of oxygen within the blood sample expressed as a concentration. The calculation for oxygen content is represented in equation form here. As you can see, the total amount of oxygen is the sum of the amount of oxygen bound to hemoglobin molecules within red blood cell, plus the amount of oxygen that is dissolved in the blood that is not bound to oxygen. The amount of oxygen bound to hemoglobin is calculated by taking the patient's hemoglobin concentration, as found on a CBC or even an ABG analysis, and multiplying that value by the patient's oxygen saturation, which can be found on the cardiac monitor as SpO2, or on the ABG analysis as well as SaO2 as we discussed. Next, this value is multiplied by a constant K, known as the Höfner constant, which is the experimentally derived value that defines the maximum amount of oxygen that can bind to hemoglobin. To familiarize ourselves with this concept, we will work out the oxygen content of the patient's blood in case number 3 on the next slide. You can follow along by entering the values highlighted in yellow from the ABG on the next slide into the yellow cells in the attached spreadsheet in the workbook titled Oxygen Content, which is shown here. We will start by calculating the amount of oxygen that's bound to hemoglobin, which as you see here comes out as 161.8 milliliters of oxygen per liter of blood, based on the formula shown there as well. This value is calculated automatically for you in the spreadsheet in the green cell as highlighted here. Next, we can calculate the amount of oxygen dissolved in blood that is not bound to hemoglobin. To calculate this, we simply take the PaO2 as measured from the ABG analyzer and multiply that value by a constant alpha, which represents the solubility coefficient of oxygen at 37 degrees Celsius. For our case example number 3, the calculated amount of oxygen in the blood comes out as 1.73 milliliters of oxygen per liter. This calculated value is automatically determined for you in the blue cell, as shown here. The sum of these two terms together represents the total amount of oxygen within the sample, which is calculated as 163.5 milliliters of oxygen per liter. This is the total oxygen content and is calculated in the purple cell in the spreadsheet as shown here. It's important to note that only 1.73 mils of oxygen per liter of that total oxygen content comes in the form of dissolved oxygen. This means that oxygen bound to hemoglobin accounts for 93.5 times more oxygen than the contribution from dissolved oxygen. This concept for overall oxygen content is so important because it demonstrates that despite our use of PaO2 in certain calculations, such as the PF ratio in ARDS, and discussing it daily on bedside rounds, its contribution to overall oxygen content for nearly all patients is negligible. Moreover, and equally as important, is that this concept of oxygen content highlights that thinking about oxygen saturations in isolation, that is, in the absence of awareness of hemoglobin concentration, falls short if we aim to understand total oxygen content for our patients. Take another example case, case number 4, with corresponding ABG seen here. Note the very low concentration of hemoglobin, but slightly improved SaO2 compared to the previous case. Again, you can follow along by entering the highlighted values into the workbook titled Oxygen Content. From these values, we see that the patient, in this case, has an oxygen content of 30.9 mils of oxygen per liter. Placing the calculated oxygen content from these two cases side by side, we can see that the oxygen content of the patient with the severe anemia is more than 5 times lower than in the non-anemic patient. And that is accounting for the fact that the anemic patient has both a higher oxygen saturation, 100% versus 97%, and nearly double the PaO2 of the non-anemic patient. We're talking about 100 millimeters of mercury compared to 55 millimeters of mercury. The reason for this discrepancy in total oxygen content, of course, is the low hemoglobin concentration, which you'll remember is our main means of transporting oxygen throughout the body. Hopefully this exercise is able to highlight how little dissolved O2, that is the PaO2, contributes to overall oxygen balance, and why we rarely act on low PaO2 in isolation when discussing cases on rounds. Now that we understand the concept of oxygen content in the blood and the factors that impact it, we can take this a step further and introduce the idea of oxygen delivery and oxygen consumption. Overall, as we support our patients in the ICU on a second-to-second basis, we're trying to ensure that there's enough oxygen available to satisfy their metabolic needs, allowing them to maintain aerobic metabolism to support and power their organs. With this, the next logical question that comes up is, well, how much oxygen is enough oxygen? In order to figure this out, we need to begin to think about adequate oxygenation in terms of oxygen delivery, abbreviated DO2, and also in terms of oxygen consumption, abbreviated VO2, which represents the amount of oxygen the body consumes on a per minute basis. Conceptually, it's likely easy to see that we're trying to ensure that there's more oxygen being delivered to the tissues every second than is being consumed. This will ensure tipping of the scales in favor of a positive oxygen balance. To figure out how much oxygen is being delivered to the tissues, we use the formula seen here. As you can see, we take the oxygen content that we just learned how to calculate, highlighted in red, and multiply it by the patient's cardiac output. This gives us the amount of oxygen delivered per unit time and comes out in units of mils of oxygen per minute. Looking closer at this formula, we can appreciate that we're able to impact the overall oxygen delivery to a patient by manipulating the components of this formula. This, of course, means that we can increase the concentration of hemoglobin so that the blood is able to carry more oxygen, or we can improve the oxygen saturations, meaning that the individual hemoglobin molecules are each able to carry more oxygen, or we can increase the cardiac output so that more blood is being delivered to the organs per unit time. As mentioned before, we can also increase the amount of oxygen that's dissolved in the blood, but this will have very little impact on the overall oxygen delivery for the patient for the reasons mentioned previously. Now that we understand a bit about oxygen delivery, we can practice calculating the DO2 for the patient's ABG in example case number 5 found on the next slide. Included in the case data is the cardiac output, which is required for the calculation. The relevant values required for the calculation are again highlighted in yellow and can be entered into the yellow cells in the workbook titled DO2-VO2 found in the attached spreadsheet. The DO2 will be calculated in the purple cell. Using the PO2, SaO2, hemoglobin, and cardiac output, we can determine that the oxygen delivery for this patient is 599 mils of oxygen per minute, as shown here. The second part of understanding oxygen balance relates to the amount of oxygen that the body is consuming on a minute-to-minute basis. This is referred to as oxygen consumption, and again, abbreviated VO2. Important to note that under normal conditions, the entire amount of oxygen initially loaded onto hemoglobin in a sample of blood as it passes through the lungs is not entirely removed and utilized by the body by the time it returns to the lungs again. This means that normally the oxygen saturation of a quote-unquote deoxygenated venous blood sample is not 0% at the most distal point in venous circulation before it re-enters the lungs. In fact, normal oxygen concentrations of central venous blood are typically in the 60 to 80% range. Because of the difference in the oxygen content from blood at the beginning of a circulation loop, that is, say, leaving the lungs, compared to the end of the loop when the deoxygenated blood returns to the right side of the heart, in the right atrium, we can compare samples of blood from these two locations and derive information about the amount of oxygen that was extracted from point A to point B. And with this information, we can calculate the overall oxygen consumption of a patient. For the purpose of analysis, arterial blood gas samples can be taken from an arterial line or an arterial puncture, but the best place to sample venous blood for this purpose is from a location as central as possible, as this represents the most deoxygenated blood in circulation. The oxygen saturations of a central venous blood sample are abbreviated SVO2 or SCVO2. One method to accomplish this is to take a sample from the distal port of a central line located in or near the right atrium. With the appropriate samples collected and analyzed, as long as we know the patient's cardiac output, we can first calculate the oxygen content of each of these samples, as discussed previously, and then through the use of fixed principles shown here, we can determine the patient's oxygen consumption. Putting this all together, we can now work through case number 6, where, as mentioned, we can use the central venous blood sample to compare the oxygen content of maximally deoxygenated blood to the oxygen of a maximally oxygenated ABG blood sample to calculate VO2, that is oxygen consumption, through the use of fixed principle. Again, all the values required for these calculations will be highlighted in yellow and can be entered into the yellow cells in the workbook titled DO2-VO2 found in the attached spreadsheet. Case 6 reads as follows. This is a 60-year-old man who's been consulted to the intensive care unit for possible sepsis. Below is an ABG drawn from his right wrist and a venous blood gas sample drawn from the most distal port of his right internal jugular central line. Chest X-ray confirms the distal tip of the central venous catheter is located at the level of his right atrium. Point of care ultrasound estimates his cardiac output at 7 liters a minute. We can see from our calculations here that the rate of oxygen consumption for this patient is 189 milliliters of O2 per minute. This value is found in the light blue cell in the spreadsheet, automatically calculated for you as well. Because adequate delivery of oxygen to tissues within the body is so important, the ratio of oxygen delivery to oxygen consumption is tightly regulated by the body. Normally, the body strives to maintain a DO2 to VO2 ratio of about 5:1, meaning that there's normally 5 times more oxygen being delivered to the tissues within the body than is being used at any given time. This ultimately ensures a safety buffer of oxygen for the body to work with, which is crucial because when the ratio of delivery to oxygen consumption falls below 2:1 during times of, say, decreased oxygen delivery or increased oxygen consumption or both, anaerobic metabolism and lactic acid production begins. If we look at the results from our calculations for case number 6, we see that we have a calculated DO2 of 984 milliliters of oxygen per minute and a calculated VO2 of 189 milliliters of O2 per minute. Clearly, our delivery of oxygen, the DO2, exceeds the consumption of oxygen, the VO2, for this patient. In fact, our DO2 to VO2 ratio is above the normal 5:1. From this calculation, we can be confident that, at least at present, hypoxemia and hypoxia is not a major issue for this patient. Also, by looking at the patient's lactate, which in this case is normal at 1.1 millimoles per liter, we find more evidence that the patient is not currently operating in anaerobic metabolism, again, at least at present. It's important to understand that there are several factors that impact oxygen consumption as a variable. These factors, which are listed in the table here, are not only important to be aware of because they can alert us to times of increased oxygen need, but also because several can be purposefully manipulated to reduce oxygen consumption, possibly improving overall oxygen balance for our patients. In analyzing this list, we can begin to appreciate the fact that the patients we regularly care for in the intensive care unit have multiple reasons to have their oxygen consumption elevated well above their typical baseline. In addition, this list also helps us understand the rationale for some of the measures we utilize in the management of complex pathology ICU. For example, our use of paralytics and ARDS and emphasis on temperature avoidance and previously therapeutic hypothermia in post-cardiac arrest patients are both examples of interventions aimed to reduce oxygen consumption in an attempt to maximize oxygen availability for vital organs such as the brain. A note on determining the cardiac output for patients. As we can see from the calculations that we've already looked at and performed a couple of times, knowing the cardiac output is vital to moving beyond just this idea of oxygen content and towards an understanding of oxygen delivery and oxygen consumption. There are several ways to determine cardiac output for our patients in the ICU. The least invasive method is through the use of transthoracic echocardiography, which is able to take several measurements of the heart through the external or the exterior chest wall. From these measurements, the cardiac output can be approximated through calculation. Although normally readily accessible, especially with the increased availability of point-of-care ultrasound, obtaining sufficient views of the heart for measurement and calculations via transthoracic echocardiography can be challenging and sometimes not possible at all due to patient anatomy and body habitus. While echocardiographic views can often be optimized through purposeful patient positioning, this is not always possible for patients on VV-ECMO due to factors such as sedation and cannula stability concerns. Transesophageal echocardiography, so TEE, is another modality of echocardiography where the probe is inserted through the mouth and into the esophagus, where it's advanced to the level of the heart within the thoracic cavity. This is beneficial for image acquisition, as by having the probe within the esophagus, the distance between the probe and the heart is greatly reduced, and thus the impact of unfavorable body habitus is minimized. Unfortunately, access to transesophageal cardiography can be quite limited, complicating the measurement and certainly the repeat assessment of cardiac output in our VV-ECMO patients. Luckily, a third option exists where we can use data from the patient and the VV-ECMO circuit itself to estimate the patient's native cardiac output. Shown here is the calculation for total cardiac output, which can be derived using 3 blood gas samples, and as well as information about the VV-ECMO circuit itself, which can be gathered from the controller. The source of these blood gas samples is also in here, and those 3 samples that are needed are: number 1, a systemic arterial blood gas sample; number 2, right from the ECMO circuit itself, a pre-membrane lung gas sample, and then again within the ECMO circuit, a post-membrane lung blood gas sample. The concept behind this formula is that when 2 blood flows of different oxygen contents mix, the resultant oxygen content of the new mixture is the average of the amount of oxygen content in each of the 2 flows. The amount of oxygen contributed by each flow is the oxygen content of that blood source multiplied by the respective flow. There's a lot of words there. This equation can be solved to determine the cardiac output. And that's really what you need to focus on here, that this formula in and of itself will mathematically tell you the cardiac output. And now we can use the attached Excel spreadsheet again, and the workbook tab called ECMO oxygenation to work through case example number 7, allowing us to calculate a patient's cardiac output as well as the DO2, VO2, and DO2 to VO2 ratio. Total cardiac output calculated in the pink cell. Oxygen delivery, the DO2 is calculated in a purple cell. VO2, or oxygen consumption, is calculated in the light blue cell. And the ratio of DO2 to VO2 is calculated in the gray cell. Interpretations of the ratio and lactate are found in the box with heading interpretation of results. So we can run through case number 7 here. So for 4 weeks into a VV-ECMO run with no return of lung function, a patient is well supported and normally has arterial oxygen saturation, so like SpO2 or SO2 values of between 90 and 95 if sedated and paralyzed. VV-ECMO flows are 7 liters a minute, and the VV-ECMO membrane lung is at 100% FiO2 with sweep gas at 10.5 liters a minute. Here below is the abbreviated blood gas analysis results from the pre-membrane lung, post-membrane lung, and systemic circulation, so just a normal arterial blood gas, and the hemoglobin is found in the chart as well. The required values for calculations are highlighted in yellow here. This is the example worked out. This will automatically be calculated for you with the spreadsheet, but through all of this math, we can figure out that the total cardiac output of the patient is 13.7 liters per minute. And this is shown here, calculated out automatically for you in the spreadsheet as well with numbers that match. Also automatically calculated is the DO2-VO2 and the DO2 to VO2 ratio found here. So DO2 in purple, VO2 in light blue, and the interpretation of the ratio or the ratio in general in the green cell there. As we can see, the DO2 to VO2 ratio is 4.3 to 1, which is acceptable and close to what would be generally considered to be normal. And by going through that example, we've come to the end of part 6. Just to recap, in this section, we've introduced the concepts of oxygen content, oxygen delivery, oxygen consumption, and the oxygen delivery to consumption ratios. We also worked through several example cases and learned how to calculate these values, as well as learned how to calculate total cardiac output for patients on VV-ECMO, which will help us in times when the traditional methods of measuring cardiac output may not be available or possible. Thank you so much for your attention today. I hope you can join me for our final part 7 of this learning module coming up next, where we will discuss the concept of overall oxygen balance and discuss troubleshooting options for hypoxemia for patients on VV-ECMO.